Small incision lenticule extraction or SMILE is generally considered a safe procedure with a low incidence of intraoperative complications in the hands of expert surgeons. Of the potential complications of SMILE, failure to extract the lenticule or a part of it presents as a unique complication known as stuck or retained lenticule. This challenging situation can be a nightmare for even the most experienced surgeons, wherein both the lenticule and the surgeon are stuck and need help. In this video, we discuss the various management strategies to manage retained lenticules in order to induce the desired effect of the primary SMILE procedure. Retained lenticules or their fragments may chiefly occur due to incorrect identification of lenticule planes, improper technique of dissection, black spots and dense opaque bubble layer, and thin lenticules. The white ring sign and the stop sign described earlier should be observed for accurate identification of the lenticule planes. Complete separation of the lenticule from both the planes as well as the side cut while avoiding excessive side-to-side movements must be employed. Corneal surface moisture should be optimum, contact glass should be clean, and femtosecond laser energy settings should be well optimized to prevent black spots or OBL. Wider optical zones and increased peripheral thickness should be used for low myopia to improve the overall thickness of the lenticule, ensuring its safe removal. Inspection of the extracted lenticule to check for any loss of tissue at the margins and thorough slit lamp examination of the corneal pocket at the end of the surgery should be performed to ensure that no fragments are left in situ. Management would depend upon size and location of the retained tissue, clinical presentation, as well as experience of the operating surgeon. Small tissue tags which are peripheral in location are generally inconsequential and hence do not require any active intervention. However, if a substantial part of the lenticule is retained close to the visual axis, a surgical exploration should ideally be contemplated either in the same sitting or at a later date. Evaluation must include an assessment of visual acuity, topography, anterior segment OCT, clinical photography, and reviewing of the surgical video for quality of laser firing pattern and surgical course. Based upon the clinical scenario and surgeon's experience, the following approaches may be employed. Refractive correction using LASIK or PRK is indicated whenever the whole lenticule is retained due to cap lenticular adhesions, but when the surgeon is not confident to perform surgical exploration, or whenever significant areas of black spots are seen during laser delivery, forcing the surgeon to abandon the case. LASIK or PRK, however, is contraindicated when a fragment of lenticule is retained, resulting in significant corneal irregularity and loss of CDVA. Topography-guided treatments may be attempted in select cases wherein the irregularity is mild and the CDVA shows significant improvement. However, their role in this scenario remains controversial due to unpredictability of results and potential risk of haze formation. Surgical exploration of the pocket through old SMILE incision is indicated in those cases of cap lenticular adhesions where the surgeon is confident in exploring the pocket to remove the stuck lenticule in order to maintain the advantages of SMILE. This option may also be utilized to extract lenticular fragments causing significant topographic irregularity as long as the laser firing pattern is normal and devoid of large areas of black spots. Pocket exploration may be accomplished by slit lamp guided dissection, use of intraoperative triamcinolone acetonide or injection of air for enhanced visualization, use of certain rescue instruments, and application of an intraoperative OCT for accurate identification of lenticule planes. Circle software is a special tool primarily indicated for enhancements after smile. However, its use in complicated smile scenarios is an off-label indication aimed at converting the cap into a flap, thereby allowing free access to the irregular interface. Open exploration using Circle software is reserved for the following complex smile scenarios: lenticule retained due to creation of a false plane, multiple entry planes seen on ASOCT, suspected cases of retained lenticular bits where the ASOCT is not conclusive, and in cases of suction loss occurring at the incision stage of lenticule creation. Let us look at some of these complex case scenarios and their management strategies. This referred case presented with reduced visual acuity, high irregular astigmatism, and elevation in corneal contour on ASOCT, signifying a retained lenticule. Surgical video showed normal laser firing pattern. Pocket exploration through old smile incision was carried out to separate the lenticule from surrounding tissue bridges, followed by its successful removal and restoration of unaided visual acuity. Another case of complicated smile revealed multiple planes of entry and a prominent false plane on ASOCT posterior to the lenticule cut with complete retention of the lenticule. In view of the multiple entry planes, open exploration with Circle was preferred and an endo-illuminator assisted lenticule separation was performed, resulting in full recovery of visual acuity. In conclusion, careful decision-making in these challenging scenarios of smile and timely referral when needed may not only help in faster visual recovery but also put back the lost smile on both patient and surgeon's face again.